সৌমিত্র, সৌমিত্র, এই দেবজিৎ, দেবজিৎ,
আপনি যে ব্যক্তিকে কল করেছেন তিনি অন্য
এই দেবজিৎ, আনমিউট কর, শোনা যাচ্ছে না। সৌমিত্র, সৌমিত্র, তুই কি আছিস? আজকে it will take another 5 minutes to start because Satyen is busy in his hospital. He'll take another 20 to 25 minutes. But Suchit is joining now. He will be presenting the first topic, that is a white QRS tachycardia and approach. He will be doing it within next 2-3 minutes. He is joining just now. সৌর,
এই তো গাড়ির ভেতরে জয়েন করলাম,
হ্যাঁ দেখছি।
আবার স্টেশনে গিয়ে আরেকবার জয়েন করবো।
এই যে সুচিত জয়েন
আগে
করে
কি সত্যেনের, আজকে সত্যেন তো আগে নাকি?
সত্যেনকে রিভাইজ করতে হচ্ছে because Satyen is little busy right now. He will take a little time. So let us start with Suchit, then we go to the
আচ্ছা আচ্ছা,
শোনা যাচ্ছে?
হ্যাঁ
ক্লিয়ার?
তো হ্যাঁ, you are absolutely clear.
আচ্ছা, আমি গাড়ি থেকেই করছি, কারণ আমাকে আরেকটা জায়গায় এখনো হয়নি।
তুইও গাড়িতে আমিও গাড়িতে, ঠিক আছে?
ও ঠিক আছে, অসুবিধা নেই। তো ঠিক আছে, আমরা
দুজন
শুরু
গাড়ি
করে দিই।
থেকেই করে।
ঠিক আছে, তাহলে আমি শেয়ার করি কন্টেন্ট নাকি?
হ্যাঁ, you start sharing. Yeah.
আচ্ছা,
তুই পারবি তো ওখান থেকে করতে?
হ্যাঁ হ্যাঁ, আমার ফোন থেকে করা যাওয়ার কথা, আইক্লাউড ড্রাইভেই আছে এটা।
ঠিক আছে।
কি ফরম্যাটে আসছে এটা? কোনো পাওয়ার পয়েন্ট ফরম্যাটে আসছে না? আসছে না,
আসছে এটা ঠিক ভালো করে আসছে না। আরো
আসছে না।
এটা হোয়াইট, এটাকে হরাইজন্টাল কর।
হরাইজন্টাল না? এবার
this is good. This is absolutely all right. হ্যাঁ,
আমি একটা ওই ফ্লো মতে করছি, মানে স্লাইডগুলো পরপর আসছে।
হ্যাঁ ঠিক আছে, it doesn't matter.
ঠিক আছে, ওকে।
So the first topic is approach to a patient with white QRS tachycardia to be dealt with by Dr. Suchit Majumdar. Suchit, please.
Yeah, thank you, sir, for this kind invitation. Actually, I am very privileged to place my topic in front of this august audience. Also, I expect for a couple of juniors also, so that they can discuss and we can learn from each other. So, white QRS tachycardia is defined as a rhythm with a rate of more than 100 beats per minute and a QRS duration of more than 120 milliseconds. And so narrow QRS is anything below 120. And narrow QRS means it's actually a synchronous activation of the ventricle, which involves the His-Purkinje system. So to have a narrow QRS, you must have conduction to the His-Purkinje system. While wide QRS rhythm indicates a less synchronous ventricular activation of longer duration, which can be due to intraventricular conduction disturbances or ventricular activation not mediated by his bundle but by the bypass tract activation, or a rhythm which arises from within the ventricle. So understandably, all these rhythms will be having a wide QRS because it is dysynchronous activation of the ventricle. And these intraventricular conduction disturbances, or maybe bundle branch block, whatever you tell, it may be intermittent or permanent. Intermittent can be rate related. During the tachycardia, the rate is very fast, and due to the phase 3 aberrancy, that time you can have a LVEB or RVB, which is rate dependent. So this is actually what I call as a wide QRS tachycardia. So the most common we know it is VT. So whenever a patient comes with a wide QRS tachycardia, if you bet on VT, you are likely to be correct in about 80% of the cases. The second common is around 15 to 20% is SVT with aberrancy. Aberrancy means left bundle branch block or a right bundle branch block, typical configuration. The third type is SVT with a bystander activation or a AVRT, which is an antidromic tachycardia. So with an antidromic tachycardia going down to the pathway, it activates a part of the ventricle, and that is almost similar to a VT, because it is again a ventricular activation not involving the His-Purkinje system. And coming to bystander activation, so it can be a usual SVT. Along with it, the impulse travels through simultaneously travels through a bypass tract, but the bypass tract is not a part of the circuit. So these all things come to about 1 to 6%. So coming to the list that I told, the most common is VT and VT and VT. It can be a macro reentrant VT or a focal VT. Macro reentrant VT are usually this thing. Reentrant and focal VT can be automatic micro reentrant or triggered activity. A second point can be an SVT with aberrancy. So the aberrancy can be a fixed aberrancy or a functional aberrancy. I have already discussed. Pre-excited SVT can be an antidromic AVRT, or it can be AT or AVNRT or an autonomic AVRT, but with a bypass tract, which is a bystander. It doesn't participate. And SVT with pre-existing non-aberration QRS abnormality, these are QRS pattern in repair congenital heart disease, like a post-fallow tetralogy repair. If a patient has an AT also, it will look like a white QRS tachycardia. Cardiac malpositions, unusual hypertrophy patterns. The next one is very interesting, SVT with anti-arrhythmic drugs. So whenever, for example, a patient with atrial fibrillation, we have given flecainide, and even after flecainide, the patient has an atrial fibrillation or atrial flutter, not atrial fibrillation. So atrial flutter, and then what causes the flecainide causes the rhythm to be wider in that situation. So this is very important. The next one is the electrolyte abnormality. As we already know that hyperkalemia and all these things can cause, and obviously ventricular pacing. If it causes some tachycardia, pacemaker mediated, then it can also cause a white QRS tachycardia. So coming to the clinical history, the age is very important. If you have, it is written that if it is more than 35 years of age, it is likely to be a VT with a positive predictive value of 85%. Then severity of symptom actually is not very helpful, because any fast tachycardia, whatever be the mechanism, will result in hemodynamic compromise and all these things. So we think that VT is more likely to cause it. But it's told that it doesn't cause, it's not important unless you have the associated LV dysfunction or other comorbidities. SVT is more likely the tachycardia has recurred over a period of more than 3 years. The first occurrence of white QRS tachycardia after myocardial infarction strongly implies VT. VT is more likely in structural heart disease. In one report, more than 98% of the patients with previous MI had VT as a cause of white QRS tachycardia, while only 7% of those with SVT had a MI. Pacemaker I have already discussed. Now medications. Medication causing white QRS tachycardia, Torsades repointed. So these are sotalol, dofetilide, quinidine, class 1A, 1C drugs, and class 3 drugs. Along with this, certain antimicrobials like azithromycin, erythromycin, and diuretics by causing electrolyte abnormalities, also maybe pantoprazole causing magnesium deficiency. So class 1 anti-arrhythmic drugs, especially class 1C, can decrease conduction velocity at faster heart rate, that I have told. It is a flutter in fast heart rate. It can cause rate user dependency of the slowing of conduction. As a result, this drug can cause aberration and widening of the QRS. Digoxin, the most common digoxin-induced white QRS tachycardia is a monomorphic VT, often with a relatively narrow QRS complex. Bidirectional VT, a regular alteration of two white morphologies, each with a different axis. Now, in clinical examination, what you can see, if it is an unstable hemodynamics, there is no question of clinical examination, just cardiography, and then think about it. If there is a stable hemodynamics, you can think of whether there is a cannon wave in the neck. If you have irregular cannon waves occasionally occurring, it suggests VA dissociation and the underlying rhythm to be VT. If there is a regular cannon wave, it is more likely to be SVT with simultaneous ventricle and atrial activation. So something coming from the junction, AVNRT and junction tachycardia. Now, effect of carotid sinus massage is important because it usually terminates AVNRT and AVRT. Sometimes can terminate an outflow tract tachycardia because these are adenosine dependent tachycardia. And it can, in a VT, the purpose of carotid sinus massage, sometimes it can expose the irregular cannon waves in a VT, which has a 1:1 conduction. So laboratory testing, hypomagnesemia and hypokalemia, I have already told, but they often don't occur alone. They occur with other abnormalities. These are hyperkalemia causing a white QRS sizzle with a slow rate and not a discernible P looking like a white QRS tachycardia. Pharmacological intervention. So if the tachycardia is terminated by lidocaine, it is likely to be a VT. If it is the adenosine termination, it's likely to be an SVT. White QRS tachycardia don't give verapamil and diltiazem because it can cause a hemodynamic instability and the patient may collapse. Except when suspecting a fascicular VT, but in fascicular VT is usually not that white. So ECG features. So ECG features of white QRS tachycardia, is it visible or is it very small?
It is visible.
Okay. Okay. So just make it wider.
But
Now it is better.
You are showing the smaller alphabets now.
Yeah, smaller alphabet, brother. Yes.
But
Okay.
the main
So
slide is on the right side.
Yeah. So yeah.
Yeah,
So,
this is better.
This is better. So ECG features, it is very difficult to differentiate between VT and pre-excited tachycardia because actually though both actually activate the ventricle as a fast thing without involving the Purkinje system. So all algorithms which are there mostly differentiate ventricular tachycardia versus apparently conducted supraventricular tachycardia. And how to differentiate, how to suspect it is a VT. This actually I don't want to go into detail because it's a long topic. AV relationship is very important to see for dissociated P wave, fusion bits, capture bits. Then look for QRS duration. If it is more than 160 with LVEV or more than 140 millisecond with RVEV. And QRS during a wide QRS tachycardia is narrower than during sinus rhythm. That is very important. That concept to understand that if you have, for example, a person with an LVEV, which is a QRS duration of maybe 156 milliseconds, and during tachycardia, you have a QRS duration of 136 milliseconds. So you most likely it will be a VT because apparent conduction is already there. So something coming from the septum, which is synchronously activating both the ventricle, can only narrow the QRS. So definitely, if you have a wide QRS tachycardia, which is narrower than the QRS during a normal sinus rhythm, is almost certainly to be a VT. Then QRS axis, northwest axis, and the discordance between axis and bundle branch block morphology also suggests VT. Concordance, the precordial concordance, negative concordance is more predictive of a VT than a positive concordance. Concordance means, for example, positive concordance means something coming from near the mitral annulus or annulus. So in annulus, all the pathways insert. So in this case, positive concordance can occur in pre-excitation and also VT. So coming to the next slide. So this is an example of what I was telling here. There are beats with where you can see the P has no relationship with the QRS. So there is a VA dissociation, and also there is some bits which are in between the which are marked with the F. You can see which are in between the width of a QRS of the wide QRS tachycardia and a sinus rhythm. So these are fusion bits, and which have a narrow QRS are capture bits. Usually fusion and capture bits occur in a slower VT. For example, whenever you're giving a verapamil in a case of fascicular VT, before its termination, you will see more of capture and fusion bits because the his Purkinje system gets chance to conduct down. So this the right side actually shows anything other than a typical LVEV or RVEV in V1 or V6 is likely to be VT. And if it's a typical LVEV and RVEV, it is likely to be SVT and aberration. Now, regarding the rate, if you find a VT which has a rate of 150, just be suspicious. It can be an AF with a 3:1 conduction and aberration. Although marked irregularity strongly suggests AF, VT can be particularly irregular within the first 30 seconds of onset, and also in patients treated with amiodarone or other antiarrhythmic drugs. AV dissociation is absent in a large subset of VT, especially those with a slower heart rate. And in fact, around 30% of VT have 1:1 VA conduction. Now coming to the comparison with a bundle branch block during sinus rhythm. In general, if the QRS complexes during tachycardia are identical to those during the normal sinus rhythm, the tachycardia is likely to be supraventricular. So that is a pre-existing bundle branch block. If you have a contralateral bundle branch block, maybe LVEV during wide QRS and RVEV during normal sinus rhythm, it strongly favors VT. If there is an identical QRS morphology between a normal sinus rhythm and wide QRS tachycardia, rarely it can be VT, which is called as a bundle branch ENT VT or an interfascicular VT, where the VT involves one of the bundles. It usually comes down by the right bundle and comes up by the left bundle. In addition, in patients with a fixed bundle branch block during normal sinus rhythm, rapid tachycardia rate sometimes can increase the aberrancy, and which may lead to a different bundle branch morphology, not different, but slightly different, which can be erroneously suggested as VT. This is very important in looking at ICD algorithms, where you see the discriminated channel sometimes looks slightly different, but then it is not VT, it's an SVT. In these cases, superior accuracy to diagnose VT was observed with the R-wave peak time. This is one of the markers to differentiate with SVT with aberrancy if it is more than 50 milliseconds or more in lead 2. Now, these are the algorithms. I am not going into detail, but just see that it is irregular or regular. Irregular straightly goes on to AA for atrial flutter or atrial tachycardia. Regular you see for 1:1 relationship. And then you see that if there is more V, it is likely to be VT, more A likely to be atrial rhythm. And if it is 1:1 relationship is there, then you go for a typical bundle branch block. If it is there, it goes in favor of SVT. Then if it is a concordant in precordial lead with no RS and onset of R2A is more than 100 milliseconds, it goes in favor of VT. Also, there are criteria in RBEV and LBEV pattern. There are different algorithms. I'm not going into detail. I think people should read those things in detail. These all algorithms have a sensitivity of around more than 95% and sensitivity of around 98%. So this is the only algorithm I could find where it differentiates with a ventricular tachycardia versus pre-excited tachycardia. All the other algorithms are ventricular tachycardia versus SVT with aberrancy. So here it says that if it is predominantly negative concordance or negative QRS between T4 to T6 is likely to be VT, because there is usually no pathway which inserts low down into the ventricle. Usually inserts into the annulus. So never it can result in a T4 to T6 negative like that. Rarely MAHEM can result, other than that, none. So if it is not there, then you look for a QR complex is one or more of the precordial lead T2 to V6. If it is yes, then VT. Then if there is a AV relationship which is different from 1:1, definitely it is going to be VT. And if it is not, then consider pre-excited SVT, but cannot be certain. That is very important point. Now, so just I will go one or few slides on the EP differential. So from my discussions, I can tell you that you cannot diagnose fully a wide QRS tachycardia as VT or SVT with aberrancy or pre-excited by this only clinical thing. So sometimes you need to go for an EP study. And EP also looks at the same categorization what I have given in the first chart, that wide QRS because of bundle branch block, wide QRS because of antegrade pre-excitation, or wide QRS because of ventricular tachycardia. And antegrade pre-excitation can be a part of the circuit.
Suchit, you are not audible now.
Hello?
Now it's okay.
Hello?
Hello?
Can you hear me, sir?
Yeah, now it's okay.
Yeah, there was an interruption actually. And wide QRS tachycardia because of bundle branch block can be any of these things which has a narrow QRS tachycardia, which associated with bundle branch block will cause a wide QRS tachycardia. You can put AVNRT or AVRT, AT, JT, everything. And
Again, there is an interruption. Suchit. Suchit. Problem.
I can hear you. The problem is that there was. Hello?
Now it's
Hello?
you're audible.
Yeah, some network issues. Sir, 1 second. So now it is audible.
Yeah.
Yeah. So actually there was a call coming. I finally changed the. Okay. So this I have already discussed. So rare causes can be. I am not going into detail. This nodal, nodoventricular and nodovascular tachycardia, and how to dissect out in EP lab. Do you want to go into those or just go into some? Hello? Hello?
Outline of EP you
Hello?
can say, but don't go into the details.
Okay. So basic things is to see for the AV relation. Sometimes it is very difficult in the visual ECGs. You may not find very well VA Wenkeback or something which may not look if you don't measure properly. That is very clear if you put catheter in the ventricle and atrium, and you can see that all V are associated with A or not. Secondly, you can go to a HV interval. This HV interval, if it is a aberrant conduction, then the HV interval will be normal, like a sinus rhythm. If it is a VT, then HV interval will be negative, because it is not coming down from the His-Purkinje system, but something which is arising from the ventricle. Also, there are different pacing protocols, so I'm not going into details on that. Pacing protocols means you have to introduce an atrial premature complex, or you have to do atrial entrainment. Now let us see some examples, I think.
Yeah.
So shall it, do we know it interactive or just I mean,
Whatever you like, go ahead.
Okay. So I think this is there is a irregular rhythm which has a wide QRS mostly, and sometimes there is a narrower QRS in between. So if you find this sort of ECG which is completely irregular, which is wide, and which has this thing, some QRSs are narrower and some QRSs are wider, the two differentiation can be AF with apparent conduction or AF with a pre-excited pre-excitation. So that you have to find out that whether it fits with a particular type of aberrancy. If it fits with a particular type of aberrancy, it is more likely to be an AF with an aberrant conduction. If it doesn't fit with a particular type of aberrancy, then it is more likely to be this thing, pre-excitation. Here you can see that V1 is negative and V2 becomes positive, and then again V3 becomes negative. So this sort of transition, which transition occurs from V1 to V3 and V2, and again V2 to V3, a reverse transition, this is unlikely to have occurring in a usual aberrant conduction. So it is most likely to be a pre-excited tachycardia, pre-excited AF. So the next one is actually a wide QRS tachycardia, which is intermediate, which is a non-sustained, and then the sinus beat is coming, and again it is occurring. So here you can see also that there is a V1 is positive, and then V2, V3, V4, V5, V6 all are negative, and lead 1 is negative and lead AVL is negative. Now, whenever you find lead 1 and AVL is negative, it is something coming from the very lateral part of the heart. Now this can never be occurring in a aberrant conduction. So this has to be a VT, because that side there is no connection with the His-Purkinje system. Usually this is a VT, and this VT is coming from the very lateral part of the left ventricle, and maybe near the apex, because mostly V2 to V6 are negative. So this is a VT and NSVT, and more likely to be an epicardial VT, because there is a slurring in the onset of the QRS. So this is another patient. This was actually the right side, the rhythm was there with the wide QRS tachycardia. Actually, if I don't tell the case, then it's difficult to tell. So there was a, this actually was an Epstein. So Epstein's anomaly you should get usually an RBV pattern in V1, V2, or if you don't find that, then you should suspect that it is a pre-excited ECG in an Epstein's anomaly. So that is very important. Epstein's anomaly, if you don't find an RS pattern, PR interval may not be very short in Epstein's anomaly like a usual pre-excitation, because the P wave is wider because of long atrial conduction time. So these are all actually both are VT only. The left one is a outflow tract, not outflow tract, maybe outflow inflow. There is a junction point. There is a VT, and the right one was also, as I remember, it was a VT. So so should I go into another case or something?
You can go to the cases.
Okay.
Okay.
So
That is
let's see
better.
this case. So these are 55-year-old female. Actually, these are all EP lab ECGs, but you can see that there is a negative, almost a negative concordance from V1 to, not negative concordance, V6 it has turned to be positive, and 2, 3 AVF are negative. And this is a wide QRS tachycardia. There is a 1:1 AV conduction. If you see the, there is a marker for high right atrium. You can see some signals which are showing the atrial conduction, and below you can see the ventricle, RV apex, RVA, where you can see that conduction, which is 2A. So here you can see there's a 1:1 AV association, and the HV, if you have measured, was positive. So whenever HV becomes positive in an EP study in a wide QRS tachycardia, we are almost certain that it is not VT. It has to be this thing. It has to be an aberrant conduction, not pre-excited, not VT, but an aberrant conduction. So this case finally, so it was a regular wide QRS tachycardia with LVEV 1:1 AV relation, positive HV interval during tachycardia, and we did an entrainment which was suggestive of AV NRT. So this was a typical AV NRT with a LVEV aberrance. Another case is a 24-year-old male patient who also had a wide QRS tachycardia, and there was a 1:1 conduction in that patient. Then in this patient, the HV was negative basically. The HV was negative. The H, so it was around minus 64 milliseconds. And finally, I'm not going into details. These are all details. So it was regular wide QRS tachycardia with LVEV 1:1 AV relation, negative HV interval during tachycardia, and on EP study we found that RV activation was occurring before his activation. Usually his activation should occur first, then RV activation, but here it was occurring RV before his. So this was an antidromic AVRT by an atriovesicular or Mahem pathway. The third patient is a 25-year-old female patient who also has a wide QRS tachycardia RVV morphology, positive concordance, and there was a 1:1 AV relation, and RDS-A was seen at the CS proximal, means proximal coronary sinus. So ventricular entrainment was suggestive of AVRT. So it was an orthodromic AVRT using the right posturoseptal constrict bypass tract with a baseline RVEV. So here also you can see the HV was positive. So finally, this is a 38-year-old male patient who had a wide QRS tachycardia, RVEV morphology, and there was a 1:1 AV association with a positive HV in this thing. Now this is very important slide. I think you can see there was a change from the wide QRS tachycardia to the narrow QRS tachycardia, and the cycle length almost remaining same. If you have a wide QRS tachycardia which changes to a narrow QRS tachycardia with similar cycle length, it usually indicates the AV NRT. If the cycle length changes, it can be an AVRT if the pathway is inserted on the same site. So this is a wide QRS tachycardia, RVV 1:1 association, positive HV, earliest stage A in CS distal, and it was an orthodromic AVRT with RVV aberrancy involving left lateral bypass tract. Thank you for that.
Thank you, Suchit. You presented it in a difficult scenario. You're not in the usual position to present.
Yeah.
Perhaps
I think I was audible or not? When I was audible,
okay. You're audible, no issue on that. Or sometimes it was disconnected, but it was okay.
Yeah.
Actually, I was expecting, as I told you, more of ECGs to and to discuss on those points rather than the EP one, because all of us are not electrophysiologists, obviously, and ECG, looking at an ECG, how to approach that becomes more challenging in a given scenario, particularly in the clinics. So you have shown some ECG. So what are and you have mentioned about some algorithm. I have gone through a wonderful algorithm given in BMJ, which I used to tell in classes that say that first take the history. If the history of coronary ischemic heart disease is there, particularly if there is an myocardial infarction, old, you consider it to be a VT until proved otherwise. Any patient of white QRS tachycardia coming to the emergency, giving a history of prior ischemic heart disease, consider it to be VT until proved otherwise. If the history is not forthcoming, you analyze the ECG. As you are telling, you have said so many points regarding the morphological characteristics like the capture bed, fusion bed, 1:1 connection, or if there is a monomorphic complexes, lateral waves, lateral wall Q waves, all these things, as you are telling, particularly 1 AVL and also in V4, V5, V6, if you get prominent Q waves, these are all similar, suggest a VT. Also the QRS duration, more the duration, more suggestive it is of VT. If it is 150 plus, it is practically always it suggests VT. That way you analyze the ECG. If you are sure from the ECG that this is VT and not VT or SVT, you make the diagnosis and treat accordingly. A number of cases remains where we cannot differentiate, despite the history and the physicals and the analysis of the ECG. If the patient is stable and if it is a well-equipped hospital, one can always go for an EP study to differentiate. But in most of the places, EP labs are not available, particularly in those hours, in odd hours. So if you have any element of doubt that this can be a VT or an SVT with aberrancy or SVT with a pre-existing bundle branch block or whatever it is, give an adenosine test. They recommended to give 12 milligram of adenosine very rapidly. If it is SVT with aberrancy or SVT with pre-existing bundle branch block, this is going to be reverted. If it is otherwise, is most likely this is VT. This algorithm came out in PMJ for quite some time back, but it is very close to my heart because I really like that approach. This is what one should do in the emergency departments of the hospitals. It is open for discussion. Anybody, you can ask questions or you can clarify your doubts. Aditi? Aditi?
Yes, sir.
You worked in the EP lab for quite some time. You can ask something, or if you have any query, you can clarify.
Yes, so most of the time it's with the ECG basically, like sometimes it's very difficult to differentiate whether it's SVT with aberrancy or it's because of the bundle branch, this or it's a VT. Basically on the ECG, sometimes the VA dissociation is not that much visible, and capture fusion beats we only get if it's a slow VT. So in that case, you said just now that adenosine test
That is one way.
But if it is a pre-excitation, then in that case, adenosine should not be given. If suppose it is a pre-excitation. So in that case,
what's wrong here?
Sorry, sir.
What's wrong there if it's a pre-excitation? And if you give,
Madam, if it's AF with pre-excitation, basically in that case, we shouldn't give adenosine.
no, AF with pre-excitation, usually what we get is with AF, as Suchit has very rightly said, there are two things can happen. One is the pre-excitation, or second is there is a pre-existing bundle branch block. He was showing an ECG where there was a likelihood of some pre-existing bundle branch block. So if the patient is stable, it is more likely that it is with a pre-existing bundle branch block. Though it is not a conclusive evidence, but it is more likely. And if the patient is unstable or the rate is very high, the sine qua non of an pre-excited AF perhaps is the rate. Sometimes it gets transmitted with a very high rate. If you get intermittently also that there is a very high rate transmission, this is more likely to be an AF. And if the patient is unstable, obviously you need to give shock.
Yes, sir.
Suchit, your comments?
No, I think correctly said, sir. Actually, most important is whenever you are giving shock or something, then after that you see the ECG, whether there is a pre-excitation or not. Usually baseline pre-excitation is very important. Usually these cases can have a baseline pre-excitation. May not have, because sometimes late lateral pathways may not have, but usually they have a pre-excitation which is present at baseline. So that way, and also what I usually see is that it is fitting with a typical bundle branch block morphology or not. If it is not fitting with a typical bundle branch block morphology, it's odd. For example, there was a reverse transition and transition. So all these things point towards AF with the pre-excitation. So what sir was asking that what is the problem in giving adenosine in a patient who has a pathway? Clearly, adenosine can induce AF. That is one of the problems. So if it is inducing AF, it can result in a conduction with a very fast rate with the AF with pre-excitation. So whenever you are, even in an orthodromic AVRT, if it is a narrow QRS tachycardia, people don't think it's a wide QRS tachycardia. So they think that I will give adenosine and that's all. I don't have any resuscitative equipment around. But that may be problematic because sometimes adenosine can induce AF and it can result in a very fast conduction and can result in a collapse. So you need to shock immediately. So whenever you are giving adenosine, I think you should have resuscitative equipment around. It cannot be given in a clinic.
No, this is what I am talking about is in the emergency department of a hospital.
Yeah, correct.
This should not be given in a clinic. That patient should be immediately
No.
referred to a hospital.
Sometimes what happens that defib and all these things are not there. That happens.
Any other issue? Devapam? Devapam, any issue you want to raise? Mita? This is a very problematic thing sometimes. All of us sometimes gets confused and perhaps we are unable to treat the patients properly. Very often, sometimes this do happen, despite all careful analysis and everything. That's why I thought this topic should be brought forward. This is important. Siddhartha, you are there?
Yeah, Shantanu, I just sorry, I joined.
Hi, Shubhra. How are you?
I'm better today.
Good.
I just thought I actually missed. I don't know what Suchit has said. I've already missed it, but just I caught the last bit. What Suchit you said, like, could you tell me what exactly you said? I mean, you do not use adenosine in a wide QRS tiger. Is that what you meant? Or,
No, not at all.
Not at all.
You can use wide QRS tachycardia, which is terminating with adenosine. it's an SVT, and so that is one of the proof regarding. Sir was already discussing this, that there was an article that told. So adenosine test is one of the things we can use. The issue is that whenever you are giving adenosine, maybe wide QRS, maybe narrow QRS, there is a possibility of inducing AS. Adenosine itself can induce AS. So whenever we are giving adenosine, we should be cautious that sometimes, rarely, it can induce AS with a pre-excited tachycardia, pre-excited AS after giving adenosine. So then the management is only DC cardioversion. So we should have a cardioverter around.
Okay, I'm asking this because initially it was told like if you have a wide QRS tachycardia, that could be due to possibly one of the possibilities could be that it has a re-entrant circuit, and if you give adenosine, it can make matters worse. So is that no more valid?
No, nothing.
Because by blocking the AV node, whether that would actually
that actually block for a few seconds only.
okay.
So it should not cause an issue.
Right.
Even verapamil and diltiazem, no, one of the considerations before was that you should not give in a wide QRS. That is correct only, but the reason has changed. Previously, people thought that blocking AV node will conduct more through the accessory pathway. That is not like that. The reason for not giving diltiazem and verapamil is the hemodynamic instability it causes in a wide QRS tachycardia, and this can result in catastrophe. So that actually was written in a Braunwald also, I remember, that reason has changed. It is not due to...
Same with beta blockers?
Same. Beta blocker, you can, that also, if it is causing a hemodynamic compromise, but it's less likely to cause a hemodynamic compromise than verapamil and...
So what would be of choice in a wide QRS tachycardia? What would you do then?
Wide QRS tachycardia, if hemodynamically patient is stable. So you can...
Suchit, 1 second. Shubhro, you just continue it for 1 minute and spare me for 1 minute.
Okay.
I'm just coming back.
Okay. Sure. Yeah. Suchit, sorry, say that again.
So adenosine can be given. It is this tachycardia, which is an AVNRT, AVRT, and all these things, it can terminate. That is the thing. Adenosine can be given safely.
Okay.
But another issue is that if you think very clearly that the pre-excited tachycardia, AVRT or something, another issue is to give Ibutylide you can give. Okay. So Ibutylide will also terminate the tachycardia acutely. And if the patient is not hemodynamically compromised, that is also recommended.
And what about people mostly use Cordaron?
Cordaron also will work. But it will take time. Because Cordaron blocks both the limbs. It blocks the AV node and it blocks the pathway also. So it will also work.
At times, see, there is an atrial fibrillation and we used to give IV flecainide, right, to terminate it. But what was the danger with IV flecainide if there is an accessory pathway? Is it a chance like it can speed up the ventricular rate?
No, because if the patient has an atrial fibrillation which is pre-excited, I don't think flecainide should be given in that case.
No, but how do we know? That is the problem. Because if we get a structurally normal heart and the patient is in atrial fibrillation, and if you give flecainide, it's not wrong, isn't it? You can give flecainide to terminate it.
Yeah, you can give flecainide.
But what if this patient has AV re-entrant tachycardia, which you do not know? So do you advise flecainide IV should not be given in atrial fibrillation, even if it's a structurally normal heart?
You are telling that the usual atrial fibrillation, any atrial fibrillation.
Any atrial fibrillation. First onset atrial fibrillation, structurally normal.
Any atrial fibrillation is a narrow QRS mostly, and maybe likely that they don't have a pathway, we can see like that. So we can give flecainide. But flecainide, the problem is that sometimes it can cause change into flutter. The atrial fibrillation can change into atrial flutter, which can conduct with very fast rate. So that's why you have to give beta blockers also along with the flecainide when you want to do.
Right. So in that case, you think like it would be better to give Ibutylide rather than flecainide in such patients for if you want?
Obviously. Flecainide is more of filling the pocket strategy, what I was telling. Ibutylide can be given. Ibutylide will be helpful. Definitely. It doesn't convert into flutter.
Right.
Shubhro, one issue is if the patient is having atrial fibrillation and there is a bypass tract is there and it is conducting over there. From the look of the ECG, obviously this will be a wide QRS irregular tachycardia. So that remains a possibility. That
Now,
that is
this is a area which really I am not very clear about. But what about if the tachycardia is the other way? I mean, it's going through the AV node. Then it may not be white QRS.
and it's coming back to the
Yeah.
accessory pathway, a concealed pathway. You mean to say?
Yes. Yes.
In that case, it is not going to harm anyway. If it doesn't have any property of having an antegrade conduction, it is not going to harm. But if it can conduct antegrade, then obviously that this is a problem. But if the usually the refractory period and the conductivity, etc., is more favorable in the accessory pathway. So if there is an accessory pathway conducting antegrade, it is more likely that atrial fibrillation will be going that way rather than through the AV node. So it will be a white QRS tachycardia and very unlike to be a narrow QRS.
Right.
If it is a white QRS, I think people will think thrice before going for the fleckenites and all. It is for the narrow QRS, atrial fibrillation always, this is a pill in the pocket, one can always go for it. But if it is white QRS, one has to be careful.
Right.
Suchit, you want to add anything to this? Your comment?
No, correct. I think this is fine. I think this can. So you should mostly it is shock. Ibutylite and all these things also take some time to work. Ibutylite is also an option, but most often we have to shock them.
Any question from anybody?
Sir,
Basho, please.
Yeah, so lot of times ourselves and also our juniors send us ECGs, and we also come across ECGs, heart rate of say 150 to 170 regular, and white QRS may be a pre-existing bundle branch block. So we are confused whether it is atrial tachycardia or atrial flutter with 2:1 block. So if we fail to make the exact diagnosis,
Our
preferred mode of termination of the tachycardia, should we go for amiodarone or ibutylite or DC cardioversion? And if we are using amiodarone, so what should be our infusion rate of the initial bolus dose? I would like the seniors to share their personal experience, because often the patient goes into hypotension or some hypersensitivity reactions, how to prevent those things.
Suchit?
No, he was asking, I think whatever I can make out, that it was a patient having a 150 heart rate is often difficult to tell whether there is an atrial flutter underneath. Because the problem, we cannot see the P wave which is inside the QRS. So in that case, to take it out, we can do a carotid sinus passage, or we can give adenosine. So either of these will reveal the P waves, and whenever we see an atrial flutter, most of the time atrial flutter, the response to drug is not that good basically. If you give amiodarone also, it usually converts within 18 to 14 for 24 hours after giving amiodarone. In ventricular tachycardia, amiodarone response is fast. For atrial tachycardia or atrial arrhythmia, the amiodarone response comes around maybe 12 to 16 hours after starting the amiodarone. So we have to wait for that time. More importantly, pharmacological or electrical cardioversion has the same risk of embolization. So whenever you are giving amiodarone, think that you have done a TE, or the patient is anticoagulated for last few weeks, or the patient has no past history of atrial fibrillation and you have come within the first 24 hours.
Is it first 24 hours or 48 hours now?
48 hours. I am just telling because I just told a shorter time, so that we don't avoid a problem.
Yeah.
Sometimes people don't say that well. No?
Right.
Yeah. In the EAC, I think not the EAC, the EHRA guidelines, they often say even maybe 12 hours may also be important, because thrombus often fall, happen quite quickly. So maybe we should have a TE done to exclude a thrombus.
That is best.
Anybody?
Because two things is very important. People should not think that amiodarone can be given just like that. any atrial tachycardia fibrillation, we are giving amiodarone. Now the thing that the patient should not have a clot. That is very important, because whenever you are giving amiodarone, you are planning for a cardioversion, be it electrical, be it electrical or pharmacological.
This
The
is
chance of
pharmacological.
embolization is there. So we have, while giving amiodarone, one should be clear that they are not having any clot, or the patient is on adequate anticoagulation. And second point, after giving amiodarone, don't expect the atrial arrhythmia to convert within the first 6 hours or 10 hours of time. It can, but it is rare.
Suchit, talking about the concordance, it has been found sometimes that the ECG is favoring VT, but you don't get the concordance from V1 to V6. So that is not satisfied in some cases. So how are you going to approach that, and what would be your comment in such ECG?
So you are also traveling, but through a different transport.
Yeah, our wavelengths are matching.
So that what you are telling, sir, for example, where the VT is coming, that is important. If the VT is coming from the, for example, mitral annular VT, so it is coming from the base of the heart. So V1 to V6 will all be positive. If it is coming from the apex, V1 to V6 will be negative. But if there is a transition from V3, V4, so V4 positive, V3 negative, or V3 positive, V4 negative, these are all mid-ventricular VT, maybe from the papillary muscle or that area. So in that case, you will have a transition. So mostly these are papillary muscle and mid-ventricular VT localized heart. This can have a transition. So that can happen.
Good point. Very good point. Any other issue? Anybody? Otherwise, we move to the second part of this program. That Satyen, you are there? Satyen?
Yes, sir.
Okay, Dr. Satyendranath Datta, he will be presenting a case. Satyen, you start sharing your screen and please present your case. And thank you, Suchit, for this wonderful discussion. And we had a good discussion. We had a very good discussion and a good presentation, so that we had some more insights into it. Thank you.
Thank you for the opportunity.
Suchit traveling? Suchit is in a car or what?
Yeah, they are all mobile.
Towards Calcutta or away from Calcutta?
No. I mean, I have to go somewhere, so I just took in the garage.
Okay. All right. Thank you.
Thank you, sir.
So,
Satyen, please.
so a very good evening to the chairpersons, the moderators, and my friends and juniors. It's an interesting case of acute stent thrombosis, which I faced a couple of months ago, and somehow I bailed out myself and the patient from that condition. So this is the case, 44-year gentleman with history of hypertension and strong family history of coronary artery disease, admitted
Satyen,
with
just interrupting you for 1 minute, for a few seconds. On 12th of June, this meeting will be physical at ITC Royal Bengal. All the details will be sent to you. Please block that date. 12th June evening.
Okay,
we'll
sir.
be meeting at ITC. So for the same program, this will be a little wider. Two cases and 2 presentations, and it will be followed by dinner and the ancillaries.
Okay,
so,
sir.
Satyen, please.
Okay, sir. So this is a 44-year-old gentleman with history of hypertension and family history of coronary artery disease, admitted with chest pain of 7 days duration and history of repeated syncopes. He showed ST elevation into 3 AVF with a complete heart block. He was in shock with a BP of 80/50, but pulse rate was maintained at the time of presentation with a 75 per minute. Echo showed ejection fraction of 40%, and there was RWM in the inferior wall. So this is the coronary angiogram we took. The left system, we can see it is devoid of any significant obstructive lesions, and the right coronary artery was occluded from the proximal part with a thrombus hanging in the start of the lesion. So he was taken straight away for PCI, So 6' GR guide catheter was used. Run through floppy wire was used to cross the lesion. It was dilated with 2x12 balloon and then stented with a 3x48 millimeter Giants expedition and post dilated with 3x12 millimeter non-compliant balloon up to a pressure of 15 to 18 atmospheric pressure. So this was the final result. We were happy and okay. We just shifted the patient to ICU. Next morning, the patient was in sinus rhythm. TPI was removed. BP was 110/70. Pulse rate was 90. He was on aspirin, clopidogrel, atorvastatin. But on the early morning in post-op day 2, the patient had, as the resident told, the patient had a VT. He was cardioverted, intubated, and ECG, baseline ECG again showed CHB. He was taken straight away to the cath lab for TPI again and a check angio. This is what I found on the check angio. The vessel was occluded from proximal part again from the start of the stent. He was again loaded with ticagrelor and he was taken for a redo PCI. Multiple rounds of thrombosuction, intracoronary GTN, Nicora, and adenosine given, and after a hard work of 1 hour or almost, we found this. So as you can see in the angiogram, there is unhealthy artery starting from the distal most part of the stent and to the proximal part where the stent was deployed in the proximal part also. So I decided to take an IVUS run to characterize the lesions and what we are exactly facing with these patients. So this was the IVUS run. We can see, I will just push it up. So as you can see from the distal most part to the proximal part, there was some problem with the expansion of the stent as well as some degree of plaque prolapse throughout the stent. The most important problem encountered throughout the IVUS was that the stent was not well expanded throughout the lesion. As you can see in the distal, there is a bit of plaque prolapse also. And in the mid part, there was an acute recoiling of the stent, and with distal mode part, there was also a under expansion of the stent. So what to do next? I have decided, because I am facing a plaque prolapse and under expansion from the distal most part to the proximal part, and I had a lot of struggle to find to get a flow which was not satisfactory. I decided to sandwich the thrombus and stent the whole lesion again. So I used a Giants expedition 348 for the distal most part and a 3.5/23 in the proximal part, and post dilated the stent throughout with a 3.5/12 millimeter NC after 18 ATM. And this is what we found in the post stenting IVUS. So this was almost well expanded from throughout the lesion, throughout the stent, and as you can see, we achieved a good luminal area, and this was the final result we got after stenting. So on next post of day 2 after redo PCI, the patient was extubated and TPI removed. He was discharged with aspirin, ticagrelor, atorvastatin, and dapagliflozin with torsemide. So as we can see, intravenous imaging has a helpful role in preventing as well as treating the complications like acute stent thrombosis. Thank you. It was a short presentation because we need to discuss a lot regarding this case. Over to the moderators and chairperson for discussion.
Satyen, thank you for showing the case. But it would have been even more interesting if you could have shown the some clinical data along with it. Whether the patient had a chest pain or what happened after the first stenting. You said that the resident said patient had a VT, he was shocked, intubated, but
and the baseline ECG after the shock was also CHB. So,
yeah, but what was the event? Any event
was the,
all of a sudden this happened?
No, the most probably after the acute stent thrombosis, patient went again into CHB, and that was a brady VT, probably the resident who is the resident seen. and he shocked the patient, and patient came back to the baseline CHP again. Probably.
Okay, Satyen, did you do an echo at the bedside to see whether it was you had any inkling of stent thrombosis? Because the patient did not present with chest pain, no HT elevation. You straight away took the patient to cath lab. But before that, if you could have done an echo and shown that there was a wall motion abnormality, at least that could have made it sure that there is something wrong with your stent.
So the patient had a CHB running, so I have to take the patient to lab and take reinsert my TPI again. So that was the first thing I had to do, and take the patient to lab. And then I decided, because the patient was in CHB at presentation and again went into CHB, so there might be a possibility of acute stent thrombosis in this patient. That's why I did a check angio. That's all. And patient was ventilated, and he could not report any symptom at that moment.
That part is okay. That part is okay. That again, it created a CHB. The most likely explanation is a stent thrombosis, reocclusion there. That is justified. Shubhra?
Yeah, my question is, when with the IVUS, you found that the stent was not properly expanded. I mean, what was the necessity to use another stent? Why didn't you just dilate it? And it did look, it would be about 3.5. I think 3 was under dilated. Even if you have used a 3-platform stent of 3 platform, it would have gone to 3.75, I believe. What stent was this that you used?
Giants Expedition.
Right. So I think, why didn't you do that rather than putting in another metal where there's so much of thrombus?
Yes, sir. That was the biggest confusion and biggest biggest decision I have to take in the lab. But as we can see, after this angio, the area, our unhealthy area expands distal to the stent, as well as the proximal part of the stent. You can see where we have just deployed the stent, the proximal to the stent, there was also an unhealthy area.
No,
So
that was probably because of the thrombus which was extending over there. When you implanted the stent for the first time, you did cover that, isn't it? You cover the area from where
yes, but what I felt that that the proximal part of the stent, along with under expansion, there is some degree of plaque where I just put the stent, and which caused all the problems to start with.
Right. So there could, but you didn't find any dissection or anything.
No. There was no dissection in the IVUS.
Ovik or Bashab?
Satyen, there is some pathological dilemma because stent under deployed or malapposition due to stent under deployed because of inadequate post dilatation. On the other hand, there is plaque protrusion most often seen whenever there is over dilatation. So two things are not matching properly.
Yes, not matching properly. And what I found is that when we encounter a vessel in acute MI, we generally undersize the stents with the visual angio. Right, the whole of the artery is in spasm probably, and we undersize the stents, and we often find it underexpanded in a later stage if we find problems like this. But the plaque prolapse was a really shocking result in IVUS. As we can see, the distal most part where the stent I have deployed, there is at least 5 millimeter area which is unhealthy, and there was a plaque as well as thrombus there. So probably what happened, what I guessed is that both the proximal as well as the distal stent was deployed in plaque, and those areas were created the problem and caused this acute thrombosis.
See, my opinion is we should not underdilate a stent even in an acute situation. What we should try to avoid is not to overdilate it. But at least we shouldn't try to underdilate the stent, because if we do that, there's more chances that we are going to run into problems after the procedure, because there is thrombus there, and with time the thrombus would get absorbed also, and the space would be there. So there'll be more chance of something happening. I think we at times become too conservative, which we should avoid.
Yes, sir. Any other options I could have used in this case? I would like to know the opinion of everyone. What could have I done better from this situation to salvage the patient from this NGO probably? What could have been a more rational and better approach to do this?
For the second time, just use the thrombosuction and GP2B.
I used multiple runs of thrombosuction, multiple intercoronary things, and I found this after an hour of struggle, almost an hour of struggle.
But again, possibility of further stenosis or stent thrombosis is high. 2 layers.
I know. Anyone,
That is
please.
one, and another thing, what Shutin was telling, there is a plaque prolapse around 5 millimeter distal to the first stent. So
Yes,
with thrombus. So that is another very dicey area which needs to be tackled, I feel. Once, and moreover, you have used IVUS. You have used IVUS. It's so good.
Any idea for future to handle these cases better in future? Any idea? Anyone? Ovik?
Ovik achish? Bashab? কোথায় কে সবাই ঘুমাচ্ছে না হর্ন রেখে দেখেছে but I think Satyen, what you have done after you tried it with, you must have given a GP2B.
Yes, sir. I have given intracoronary GP2B. I have given adenosine. I have given Nicoran. I had almost 10 runs of thrombosuction in this patient.
So after that, you achieved a fair amount of flow, but the artery looked really unhealthy.
Yes, sir.
And
that's why
I agree with you that your choice of using an IVUS was fully justified in this scenario. And after, with the IVUS picture, as you are telling that there is a distally, there is a significant amount of plaque prolapse and thrombus. I think it is, I would have also gone for a second stent. I wouldn't have left it as such, as it looked not very healthy. Shubhra, your opinion?
No, it's okay. He has tried everything, and as a last resort, he has put in a second stent because it was suboptimal. So I agree to that. What I was trying to say is, instead of, I mean, I would have actually tried to inflate it, and if he has already done these things, I don't have anything to say. But yeah, you can certainly do it as a last resort if it doesn't happen. Only my concern is that ultimately in a very thrombotic milieu, we are putting in
2 layers of metal,
concern.
so that is bad.
Yeah. But as a salvage, that's okay.
This patient needs to be closely followed for some time at least, because
he's doing okay. He's doing okay. He has done 2 follow-ups in the OPD in the last 2 months. He's doing okay. He's a young guy with just hypertension with it, nothing else. So probably he will survive. He survived.
No question of not surviving, but the risk of restenosis rather than a rethrombus, and restenosis will be high in this particular.
I thought every option, sir. I thought of putting the patient in GP2B infusion for 24 hours, then take another angiogram after that and see what is going on there. But at that moment, I decided, look, I am not gonna leave that those both unhealthy areas distal to the stent as well as proximal to the stent. That's why, as a last resort, I just went for sandwiching the stent and get a good flow. That's all.
Yeah, another thing is about the prolapse. If the prolapse is substantial in a patient with acute coronary syndrome, then it's better not to just do balloon dilatation. Then balloon dilatation may cause further thrombotic.
Yeah.
And I could have lost the flow again.
Yes, absolutely. In that case, stent may be better.
Things get messed up. if you only dilate it.
Yeah.
Every possibility. Any issue, Somnath?
No, sir.
No, you would have done the same thing, or any other way. You would have. Did you see the case?
No. Partial.
So by
Yes, partially. I would have done same thing.
you would have done the same thing. Any difference of opinion from anybody? Ovik, you are here. Ovik, Bashov, Mita.
No, sir.
Mita, any difference of opinion, or you have done the same thing?
No, sir. Sir.
That is the easiest way to not to speak. Good.
No, I have one question to Satyam. Just since you have the facility for IVUS there, so why didn't you do it when you did the stenting in the first place?
Yes, that's the biggest question. There was financial problems. The patient was a government scheme patient, and in acute situations, we generally avoid doing unless there is anything to specially to look for. We don't usually do IVUS in acute situations.
Right. আর কিছু যদি প্রশ্ন থাকে খুব ভালো।
উদয় কোনো something new, কিছু নতুন আইডিয়া দেয় যদি উদয়।
I would have used 2 stent rather than the single stent on the very first time.
Okay. Proximal part covered.
Yeah, I will cover the proximal part as well as the distal part, both the cover. Because 48 millimeter was not enough to cover up the whole part of the knee.
It seems like that in the check engine, right?
Yeah.
But in the first place, I didn't think that I am landing both sides.
Can you show the first shot
Okay,
after
sir.
the stenting?
Okay, sir.
Post stenting angio.
To the right of the screen for everybody.
এটা কোন শটটা দিয়েছিস তুই?
এটা ফার্স্ট পিটিসি এর পর, ফার্স্ট স্টেন্টিং এর পর।
আচ্ছা, right.
There is only one thing that the video was occluded with the thrombus. I didn't go to open that. Otherwise, I was satisfied with the final result.
Yes, can you hold the right side one? Hold it.
Can't hold it,
Can
sir.
you
It's a
pause
GIF
it?
image.
This one is the final result.
Final result of the first stenting.
After the final, there is a little bit of wasting there.
In the distal most part.
Yeah. When there is a bend, there is a little bit of waste.
And then also proximal, there is also some haziness.
Proximally, there is a slight haziness, agreed, but distally where he left, there is some irregularity after that. But that is extending almost up to the bifurcation if you see it closely.
And this is an acute setup, so this much of flow, I think all of us
this is
accept in an acute setting.
Uday, how far you would have gone?
Just proximally will come just after the
Proximally,
after the conas, just after the conas. Just after the conal branch.
Proximally, you can extend it a bit. Yeah, but it is there.
Distally 2-3 millimeter. Distally 2-3 millimeter max.
But there is again the irregularity is there even after that. You see that there is some lesions are there. It is not that is a very healthy zone. So distally where he has left, looking at the angio, I think that is reasonable. I think that is reasonable. But proximally, Satyen, I think perhaps if you would have extended it a little more, a few millimeters after the just after the conus branch, if you would have given, perhaps the proximal part would have been better. That
Again, I have to use a second stent then, which
yeah,
I avoided in the first place. It's a 48/3.
a huge one, yeah. Shubhra, any comment?
No, I think I agree with you. I also thought like the proximal is, there was definitely, as Uday also said, there was a haziness in the proximal segment. So that needed to be covered. Distal, I don't know, there is a diffuse disease, I think. Some
There
disease
up to
there.
the bifurcation, right?
Yeah, without an IVUS, it's very difficult to say where is the healthy zone. But I think I would agree what is done, but probably they'll just have covered the proximal segment.
Yeah, that is what I'm also thinking.
Sir, I have a question. How much safe of ticagrelor use in a patient having stent thrombosis, CHB, VT with conduction anomaly?
How safe it is?
How much? Is it preferred prasugrel is better than ticagrelor in this scenario?
Acute coronary syndrome, head-to-head comparison, prasugrel has been found to be better, definitely. That is one good randomized control trial involving more than 5,000 patients, which showed that prasugrel is superior.
Particularly in this scenario.
Yeah, no question on that. But we use all that drugs, but I have a preference for clopidogrel, no question on that. But people,
I used it in the first place, but
people use ticagrelor, prasugrel, clopidogrel, all the three, which is better. The European guidelines, they prefer the last two, and particularly after the trial, prasugrel may be preferred over ticagrelor, but well, it is an individual choice because so many other things also needs to be considered. Prasugrel has some definite disadvantages like body weight, age, and other things. History of TIA, all these things. If that is compliant, you can use prasugrel, no issue.
In this context, I have a separate question to you people, that ticagrelor, regarding ticagrelor use, did you experience any block or sinus pause really, or experience any shortness of breath really in your patients? And if so, then what percentage of patients are you experiencing such kind of thing during your follow-up?
Well, if I have to give my opinion, I think shortness of breath does happen, and often the patients tolerate it after a few days' time. But I have actually, on a few instances, changed the ticagrelor. Not all patients have complained that they feel better, but some people have said they feel better. I think shortness of breath is not very uncommon after ticagrelor. But coming to the arrhythmia, I mean, for example, in this case, he developed a complete heart block because the RCA was thrombotic, and that's the reason. So I would not be really concerned about using ticagrelor in this case. I would use ticagrelor only if something has happened after putting the patient on ticagrelor, then I may think about changing it to something else. But just because the patient developed a complete heart block because of stent thrombosis or because of MI, that's not an indication that we should not be using ticagrelor.
Agreed.
Sure.
Now, his question was, which is more preferable, ticagrelor or prasugrel in this particular scenario? On that, we have that trial. What is that trial?
SR.
Plateau.
ISR React 5.
Not plateau,
ISR
not plateau.
SR 5.
ISR 5, right.
ISR.
There,
Sir, it is
nearly
not a large trial.
5,000 odd patients.
5,000 odd cannot compete with 7,000, 17,000 or 13,000.
No, that
But
is the head-to-head.
okay.
This is the only head-to-head trial between
Yes, this
clopidogrel
is
and
perhaps only
between prasugrel and ticagrelor. That is the only head-to-head trial. Shaura, anything?
Yeah, talking about that dyspnea and that pauses, it has been clearly mentioned in the plateau that none of the patients required pacing as far as pause was concerned. None of the patients required, any intervention as far as the dyspnea is concerned. So these are the side effects which are only theoretical. So there is no practical implication for these side effects.
Sir, perhaps this is not theoretical. Perhaps this is not theoretical because it is my experience that after prescribing long-term use ticagrelor after 7 or 8 months, halter documented causes are there, and patient complained of reeling sensations. And dyspnea is also after withdrawing the ticagrelor and changing it to clopidogrel, the dyspnea subsided. And this is not perhaps theoretical. And you have to be cautious enough. And you can do halter monitoring after 1 year also, or after 6 months.
It's theoretical in the sense that the side effect is very much there, but the side effect is very well tolerated, and the patients do not need discontinuation. This was the language used in that particular trial. And regarding this halter and all that, the pauses are of very short duration. Since the patients do not complain about dizziness there, so maybe you don't even need the halter monitoring. You don't need to go for any intervention. They won't be in long pauses there.
This patient was a 44-year-old guy who has a baseline after revascularized sinus rhythm without any degree of conduction abnormality. So, in the first place, I used clopidogrel. Second time, because the conduction defect is correctable and due to a stent thrombosis, I used ticagrelor. Because once the vessel is open, the patient comes back to the sinus rhythm, and in the sinus rhythm, he has no baseline conduction abnormality. So let's see follow up if he develops pause or not.
That is expected. My one question to anybody can respond. That is a patient with sinus node dysfunction or sick sinus syndrome had an PCI for an ACS or STEMI, whatever it is. And is it prudent to put that patient on ticagrelor, or we should avoid ticagrelor and give something else? Because the patient had a pre-existing pauses and a known patient of sick sinus syndrome, though not very symptomatic. That's why pacemaker was not done.
I think there the logic dictates that you have to avoid ticagrelor here.
Yeah, perhaps so. Perhaps so, because it causes some degree of this sinus pauses and all. So that it is nothing is mentioned in the guidelines or anywhere in this particular scenario, an asymptomatic sinus node dysfunction. But as Shauro has said, the logic dictates that it is better not to use something else. And none of us are telling about the bleeding complications. I'm really afraid of that bleeding complications with the more potent antithrombotic drugs. So one need to match, one need to balance the risk of thrombosis versus the risk of bleeding before selecting the antiplatelet drug. If the risk of thrombosis is not very great, clopidogrel is good enough. We have used it for decades. But if there is a risk of thrombosis, as it is in this case, the patient was on clopidogrel, patient developed as acute stent thrombosis. There is no question that clopidogrel should not be used in the second term, a more potent drug to be given. And Satyendranath has given this ticagrelor. Uday wants to give prasugrel. I think you are logical for both the drugs, but clopidogrel, we should not discard it just because the European guideline has said if it is not available, you use clopidogrel. In our country, perhaps clopidogrel has a very good place to stay. Show a comment.
Very nice discussion. The case was a very short, presentation was short, But as Satyen has rightly told, that there was adequate scope for discussion, and we need not go for elaborate description of the cases, because it's more healthy to have the discussion rather than the case only.
Yeah, right. So just repeating the same thing that we will be having the next on 12th of June, we'll be having this meeting physically at ITC evening. I will send the detailed program. The next meeting will be held as usual after 2 weeks. I may not be there, going out, and I may not be in a position to join the meeting. If it is possible, I will certainly join. Otherwise, Shobro and Shomitra, they will be there to take up that meeting. So just keep in mind that next Sunday you may have to be here for a longer time, because I will not be there.
Only my schedule will be the same. Okay, partly in a taxi and partly in a train. But I think it's better to entrust the thing to Shubro.
I will tell Shubro as well as Shomitra, to both of them. To both of them. Okay then. Thank you everybody for this lively discussion, and let us say good night to everybody and have a good next week.
Good night.
A good, fully active week in front. So bye bye, and sure to have a nice journey.
Thanks.
Thank you, sir. Thank you.
Thank you.
Thank you, Satyen.
Thank you. Thank you.
Satyen is a good case. It's a good case.
Thanks, Satyen.
Good.
Well done. Well done.
Okay. Bye bye. Bye.
Hi, Dhruv. Dhruv. Can I log out the meeting?
Yes, sir.
Can I log out the meeting?
Yes, sir. I think so. The meeting is over, so you can log out.
Okay. Thank you.
Thanks, my